Hello, everyone. I'm Nazik Hamad. This is a continuation of the video series we have for prior to our workshop on faculty development for African oncologists, which is going to happen on November 5th during the AORTIC meeting. And here we'll be interviewing Dr. Verna Vanderpuye, who is a consultant oncologist at the Korle-Bu Cancer Center in Ghana. A lot of you know her as a leader and as a teacher and educator. She was a recipient of the International Women in Cancer for Mentoring from ASCO. I'm recording this, we're recording this video, but most of us are in the hospital, so please, we apologize in advance if sometimes you will hear some announcement, but that's the world we live in. And so Verna, it's nice to meet you. I'm going to be asking you some questions regarding career development, regarding career transition, regarding mentoring and leadership. And I'm hoping we will draw on your experience in this regard. So
thank you very much, Nancy, for the introduction. Yeah.
So one thing we wanted to highlight in the faculty development is a career development, and one thing that we talked about is career transitions. From early. There are several ways of defining it: early to mid to late, and either by academic promotions or certain milestones that you set for yourself. So I was wondering, from your own experience, how did you define that for yourself? Did you actually define it, and what your advice for the younger generation as to how to go about this?
I think the first step is to identify what you want to do in life, set out your goals and your priorities, and that can be very tough in Africa, especially in the field of cancer care. It's still quite new for a lot of us in Africa, and people just think it's not much different from general medicine. So it's very murky for us in Africa, but how do you shine? How do you develop yourself and attract other people to do so? That really is a real thing. And are you even in the right environment that would allow you to progress your career? So the first thing I did, we only had radiation oncology as an option. Unfortunately, you have to go outside in our time to get trained. So maybe you were lucky enough to do that. Then you realize you're out there, you're coming back home as what? So you're coming back home not just to treat patients in your country, but also to develop the faculty, to develop the profession for people to take up. Now, are you willing to do that as an individual, or you're just coming to work to see your patients? And in Africa, you might come up to nothing. Are you willing to develop your facility to be able to train more people, to be able to reach the heights at which you expect yourself to be at? It's very murky, but it's something that can be done. For me, I just thought, okay, I wanted to be a specialist. I wanted to do cancer care, maybe by default, but I didn't want to stay at the bottom. I thought I should rise. So my issue was how to rise. There's so many different ways to rise. I have a very weird story. It might not be the same for everybody, but the easiest way is to go through the university, through the medical school, to earn your professorship and a lecturership. Over here in Ghana, it's a little bit more different for us because oncology is really not known academically, let me put it this way, compared to other African countries indeed. It was quite a tough ride, but I'm like, okay, I'll just go through the regular government system and see what I can do. Just that you should do your best at whichever level, wherever you find yourself. I think that is how, and then as one of my mentors said, just volunteer for a lot of things. And that is what, creates the path for you to develop yourself. So it's not just that. We have a regular line of progression in your career from senior specialist to senior consultant. Apparently, you have to apply for it. You have to do a minimum of 5 years post your training. The training in nowadays is totally different from the training nowadays. Unfortunately, in Ghana, because we have clinical oncologists, which is different from other parts of the world. It's quite a long process. We realize that 4 years might not be enough. It's barely enough for just one discipline. Unfortunately, to complete as a consultant, which is the highest level, you need like almost 8 years of training. That is tough on anybody. But the difference is that after your first 4 years, it doesn't make that much of a difference because you're really just working and just applying the principles of the training institution to come out. But people don't realize it that way. They just think it's so difficult to become a consultant. So that is what I found difficult for me to make. For me, it was easy. 4 years, I'm out. I did an extra fellowship for medical oncology and I was out. I was on my own. But for the new group of people that are coming, it's longer. I find myself, how do I merge the two? Because for me, it was easier, truth be told. For them, it is more difficult. So how do I guide them to get to that point? That has been very difficult for me. And a lot of people, unfortunately, have fallen along the way. I just tell them, I think you're going to regret this, but I think you need to. And along the line, I just realized that everybody is different. So that's why I say you have to decide from the beginning where you want to be along this career path. We can't always go right up to the top all the time, and you need to accept that. It's painful as a trainer to see your trainees fall along the. They didn't fall. They just didn't attain maybe the professorship that you wanted to be. You need to learn to accept that because that is where they are. So times have changed for me versus what it is now. I'll say it was easier for me because there were very few oncologists in my country. We were one of the pioneers. So it opened up avenues, but now it's a little bit more difficult. There's a lot more in oncology, both in radiation and medical oncology. It's tough trying to keep up, and then also you have your own, I would say, political hiccups. So you can't have more than 5 consultants at a time in a faculty. So technically, it means that there's a limit to how many people are going to attend this position. How do we approach our political persons to say, we need to expand this some more? Oncology is, an orphan faculty. That's how we call it. That's the only way we're able to attract people into the faculty. So we don't have to go through the hoops of working for 4 years before you can join the residency. It's different in every country. It's just a way of supplying doctors to other parts of the country. And there's really nothing wrong with that. But along the way, people rather do a 2-year program or a 4-year program and not this long 7-year program. So for me, seeing myself go through, I'll say it's kind of, I would say luck and maybe fate, that it was easy for me to just go from trainee. You were sent by the government, you came out, you got a position, you worked through the position, you got your position, there was a training college available, that is the college, postgraduate medical training was available. So we got absorbed into that and automatically became a senior person, a mentor, but it's a little bit more different for people of today. But it doesn't mean that the road has ended. It might actually be the beginning of the branching of the tree because people are now aware about oncology. And I think even if we train the young people, we're able to even branch it even further. So I think there's a lot more that we can do than we were able to do to look. But so Africa is a little bit difficult, but I think the horizon is bright. I think there's a lot that we can do to progress ourselves along the way.
So from what you're telling me, it seems that there are so different challenges. First of all, defining what the profession is, where the place of academic oncology is, and also having attained what you have attained today from publishing, from leadership. It seems like you don't have to be in that sort of like assistant professor, associate professor to attain what you have. So that's, and then again, that we still, there is people are in the foundation stage whereby the young generation can actually sort of advocate for themselves, create a space whereby the profession can give them what they want. Do you think they have, what are the, what's on their side right now in terms of, for younger people, in terms of collaborating, in terms of making research, in terms of changing policy, and how do they go about that?
I think that they have a lot of leverage right now because everybody's now jumping onto the what bandwagon of improving cancer outcomes in their country. That is the first step. People are now acknowledging and recognizing oncology as a separate specialty. There are still very few of us, and this is the time to grasp onto what you have and see how far you can go with this. What you're doing is not just developing yourself, but developing the profession and your country and your patients, if you look at it that way. The financial aspect is a different story, but this is Africa. You never be, adequately enumerated, but it's about how you feel inside of yourself. So what they have now is social media. They have internet technology. Everything is easier. I remember our days when we had to do research and used to go and look for index medicals in the library to be able to jot down the papers you wanted to reference. They don't have that problem anymore. We tell them so often that things are so much easier. Mentorship was not on the board in our times. Now it is. It's even done virtually, so you don't even have to go there. But the problem I see here, and also I'll say the governments are more into, there's a lot of talk about universal healthcare. I think the driver is cancer care, but people realize how much the cancer patients were worried. For us, it's about costs. All these things are now becoming available. The drugs are more available. Things are so much easier for them in terms of developing their country. Of course, it comes with other problems because in terms of the social networks, we have other problems of distraction. They are distracted now by, spending so much time on your phone, on social media. But that could be harnessed back towards developing your career. It's difficult, but I think it's something if they want to put themselves through, they would. They have a lot more than we had, and I think it's so much easier. They can network with, we didn't even have that many colleagues. I know in our times, because of the IEA, we met each other, we spoke to each other, we networked quite a bit. They don't seem to know that much people because they didn't travel out that much. But I think a lot can be done on social media. Networking can be done on social. They have AORTIC in Africa, where they can meet with other colleagues. I think we are not marketing AORTIC that much because a lot more people can benefit from AORTIC. Not just making friends networking, but they can develop their careers, they can develop their fields, they can do more research to improve the outcomes of cancer patients. There's a lot that we can, but I think we're not going out to hold their hand and lead them into AORTIC. For me, that is the biggest headache because a lot of things are happening in AORTIC now that is to our benefit and to the younger people's benefit. So I think we need to do a lot more in bringing these young people into our organizations to show them the way, what mentorship has done for us, what you can do, publication. You don't have to be in the university to publish. There's a lot of more things that you can do, So I think this is something that we have to, it's difficult when it comes to the females, I know. I'm not a good example because I just have one kid, so it might be a little bit easier on me than other people, but it doesn't take away the responsibilities and how to balance, your life. And like one of my mentees told me, don't expect me to be like you. That's one thing she said. Don't expect me I don't want to be like you. And that was a big lesson I learned along the way, that everybody, and that helped me a lot to realize that everybody is entirely different. You have people who come to you and say, I want to be like you. What can you do to help them? Those who don't want to be like me, yes, but there are other aspects of life that they could actually excel in without being like me. So that is what you need to help them to find that little niche where they can, excel. Or at some point in their life, they're not interested in doing something in particular. But along the line, they would be. And you have passed through this path. So it's your turn to teach them, to lead the way. And sometimes like, oh, well, I'm surprised you're actually doing this because I thought you didn't like to do it. But probably by guests watching you, even though they said they didn't want to do it, they realize maybe the satisfaction you get out of it. And that might help them along the way. They might turn they might change their mind about the way I feel about things. But like I said, it's like having 5 kids. Everybody has a different temperament, but you want to try to guide them towards being the best that they can in the interest of the profession, in the interest of the country, in the interest of the continents. So I think they have a lot more than we had, really. Yeah.
Excellent. You touched upon so many things. You touched on career aspirations. You touched about mentor-mentee relationships and women in oncology. And so, I think in terms of one thing that people wanted to concentrate on is and how to be a good mentee. So what's your advice for the younger generation in terms of how to get the most mentorship?
I think oncology is now, cancer care is now very, very broad. It's not everybody who wants to be a clinician. I think that's one thing we always have to remember. And don't think that because you're not a clinician, you actually also can't impact cancer care. I think that those areas are actually mad, and I think that's what we need to bring out. So you could be a statistician, but you could excel in the field of cancer care. You could be a physicist, not a clinician, but you could do a lot in your little area to improve the outcome of patients, and you need to write about it. I keep telling you, we don't write anything. We don't say anything, so nobody even knows what we do or how much we can excel ourselves. People don't seem to be aware, of this. So I for one, I think that it's difficult because oncology is now broad. So some people don't want to do research at the beginning. They always change. You can't force them. Everybody is different. Some people also want to do, for us, it's even worse because we have clinical oncology. It is so broad. We used to do everything, all the cancer, except for hematology, of course, all the cancer, but it's just not feasible because one field is so huge. Lung cancer is so huge. It's difficult for us, as old-fashioned as we are, to limit yourself to one area. You understand? But you know how the young generation, they like to choose just a little tiny field and concentrate on that. But you can't do that in Africa. Again, because we are limited in numbers. So why don't you make it a point to train more people? You, the young person who wants to limit yourself, so then you can limit yourself to just one field. And that actually is what makes it difficult. I'm sorry. Can you pause it? Sorry. I need to just turn this off. Okay, you can go back to recording. I turned it off.
Okay, I think we can go back.
Yeah, sorry. Yeah.
As you know, I'm not tech savvy as the younger generation. Maybe we should have one of them join us in this. But we won't keep you long. I know you're very busy. But you touched also on that the newer generation, not only do they have to kind of decide what they want to do, but they have still a role in defining the profession further, like the career pathways, what is the best career pathway for in Africa or in their setting. So I guess because they have a lot to do, and it's an exciting time, I think, in general.
I think it's a very exciting time. I agree with you, Nazik. But how do we get our young people to realize it is an exciting time? I think they are still blinded by the limitations for me, because maybe the mentors, as we are not exposing them to the possibilities out there. It is frustrating also for us. We try to expose them, but they also have limitations. Maybe they can't travel, time off work. Some people don't want to be glued to the computer like we are all the time, writing out some paper or the other. So I think it's about the mentors choosing the right mentees for the particular field. So I think it's getting engaged with your mentee, trying to find out what their exploration. There was one mentee I had who actually wanted to separate into another field of oncology, but I knew she was so good in the one she didn't want that I'm like, no, that's not possible because you excel so much in this. You cannot tell me you want to do the other one. And she's like, no, I don't want the other one. I'm like, but eventually she figured it out. And she stuck with what I thought she should be sticking with. But it's just through, observing them and saying, no, this is just not possible. But if you really want, I think the best thing is not to tell anybody, don't do anything. Because I think that is when they are more curious. And so I think you should allow them to also explore. Career pathways, we are limited in Africa. Like I said, there are not too many people who can rise to professor. There are not too many people that are going to be engaged in the medical schools. It actually limits what we can do. But I think this is also the time is right to also talk about private pathways, like private institutions, private care launching out. We don't do that because we stay where we trained, which is in the academic centers. We're now talking about decentralization of care.
Sorry, I will have to mute. Sorry, that's a hospital setting for you. Yeah, so I think what you mentioned also is that I've noticed also that those who are engaged in AORTIC in the regional societies and tend to engage in research are emerging as leaders, are emerging as, and I think perhaps that's our role, is to make sure that they take over the platforms, and then they can influence all the other, the emerging cadre. And this is what's happening in Africa, is that the emerging cadre of young oncologists is really defining the scene, is kind of interacting with the world in a very, confident manner. I think it's really changing things. So going forward, I think we don't, as I said, I don't want to take more of your time. What about leadership? Do you have any advice for the younger people? And also, do you have advice for people who are in mid-career or late career as to what they should do, to foster academic oncology?
Late career can be tough because then your priorities change a lot. But I think that might be a time to do a lot of collaboration, because we have a lot of international organizations who actually want to collaborate with us. Africa is still a virgin field, so people can still find out a lot about what we do and how we manage. They want us to articulate how we choose our treatments, because it's totally different from the West, but nobody knows how to do that. So why don't we do that ourselves? These are things that we can explore. When do you decide when and what to do? If the patient can't afford a particular treatment, which is the standard of care, what next to do? And maybe truly the patient does get some, but we don't seem to. I think as late career, we have seen it over the past decade and more. This is the time to sit down and write it and explore it. The problem is always the funding, but just writing just what you experience, your younger mentee can actually take it up to actually expand this. So for late career, some of us are winding down and saying, we don't want to do this anymore, it's too stressful. But this is the time to sit down and maybe concentrate on the things that are important to us. So maybe I'll concentrate just on, maybe I never did pediatrics, but maybe I would now go into pediatrics and see what I can bring out of all my years of experience in terms of patient, what can be done with my patient, what are the truths. We don't have people on the ground who are telling it as it is. I think that is a major thing. And for those of us who've had experience over the years, we can even tell the history. There's a beauty about telling the history about how we arrived here. I think these are things that are good for, and somebody might pick you up along the line and you probably get something else to do while you're on pension. But you're still contributing to the society.
I think you're
same thing as the young. Sorry, yeah. Same
no,
thing with the young.
Go ahead.
Yeah. Same thing with the young.
And a very important aspect, which is telling our story, because for a lot of the young people, what's happening in their own center, what's happening with their own patient, their own environment, is not as interesting as what is being published in the big journals. But actually, I tell them this is more important. This is where, cancer care is happening and where improvement is going to happen. So I think that should maybe start from the time they're very young to the time they're in their mid-career, is that our story is the real thing. It's very interesting, and that's where they should concentrate their efforts.
Yeah, because that's something we always say. When we came back to Africa, the patients couldn't afford a lot of things. So we started giving capecitabine. It was a tablet, it was a siting for colorectal cancer. In the early stages, nobody did that. It was only for metastatic setting. And now it's the standard of care, but we never wrote it. We never told anybody that that's what we do. We never write it when we tried topotecan for ovarian cancer and it didn't work. We didn't write it down until a few years later, somebody would say it doesn't change anything. So there are a lot of things that we have our own experience that could actually change or inform practice outside. What do you call it, right? Reverse something or the other. Reverse innovation or something. These are things that some people sit down and think that, well, maybe that's something to think about. The young people, I think they can make these observations. They have read things that right now, oh my God, the information, there's everything anywhere, easily accessible to people. So there's a lot of things they can read. There's NCCN guidelines, there's up to date, there's ISMO guidelines. There are so many guidelines. So now, but you can't apply them in your setting. Is anybody writing why and what to do when this is not available? How easy is it to implement? What is the difference between the NCCN and the regional guidelines versus the one for high income? How do your patients perceive that? How do nobody has even done the trial, the study to see what is the uptake in our institutions. There's so much to do. It's not just academic. There are so many, even patient advocacy. Those are things that we should be doing, but everybody's just doing about the clinical care. Patient advocacy, we're not even doing that. Even going into industry in oncology, there are so few of us, but I think that is an exciting world, helping people to decide what drugs are good for Africa, looking at the data. Do you have enough Black people? Do you have enough people from the African Genomic Study that have actually taken this medication to see what are the toxicities? How different are my toxicities from yours? What are the dose limiting rates? So, okay, palbociclib, it's 125 milligrams, but we can't tolerate it. Is anybody writing that anyway? You just hear our colleagues saying, oh, my patients all get neutropenia. So, but are we saying, can we just try starting at 100 and see how our patient, nobody is writing. They are exciting times, Nazik. There's so much we can do. Advocacy, there's even, patient counseling. I think we are even the best psychologists. We can branch into psychology because we've treated the patients. You stop treating the patients, you're 60, you're 65. That is something you can do. It's probably a 1-year course or a 2-year course. I think we'll be the best people to do this and guide psychology. In terms of cancer care, we know what the patients go through. I might probably even have a fertility clinic for cancer patients. Nobody talks about this. Nobody talks about why we can't talk about genetic inheritance for our cancers. Because the families are shunned. But nobody's writing that anywhere. But nobody's doing any research to talk to these patients. So there's so much out there that can be done. There's so much out there that can be done. You can create so many careers. We all just think it's just doing radiation or chemo. No. But I think, how do we encourage our young people to explore these opportunities? And even our old people, including myself, to explore these opportunities. These are things that we can be doing on the side as hobbies and make ourselves happy and our patients happy and get something good out of this. So the horizon is bright. And I think AORTIC can help us to do that by getting in touch with the right people. Yeah.
Wow, amazing. I think you've kind of written a whole roadmap for lots of people, young people, mid-career, late career. And I think this is a great opportunity, this faculty development project, which is going to be actually longitudinal and ongoing. Thank you for providing all these insights and wonderful, really outlook on how things should go in the future. And we would like, I'm hoping people will join the workshop and also the modules and the future activities as we actually, as African oncologists define the profession, define the career pathways, and define the best way for them to engage and improve patient outcome. Thank you so much.
Thank you so much, Nazik. Thank you. All right.
Let's stop the recording.
Okay.